Okay, good day to all. I am Dr. Comia from Manila Doctors Hospital. Our first case is entitled Wake Up Surprise, and we begin with A.E., a 52-year-old male who sought consult at our clinic due to unilateral drooping of the left upper eyelid. 3 months prior to consult, he underwent total thyroidectomy with neck dissection for stage 1 papillary thyroid carcinoma. In the immediate post-operative period, much to his surprise, the patient noted a sudden onset of drooping of the left upper lid upon waking up, accompanied by hoarseness. No accompanying symptoms were noted. There was also no history of eye trauma. The patient initially thought that the drooping would resolve, but much to his dismay, it did not, thus prompting consult with us. Past medical history is irrelevant to this case. Neurologic exam was normal with no cranial nerve deficits noted apart from the hoarseness. Patient had good visual acuity in both eyes, and in gross eye examination, there was noted ptosis of the left upper eyelid. Pupils were anisochoric with the left myotic pupil measuring 2 millimeters, while the right measured 3 millimeters. Both pupils were reactive to light, and there was no relative afferent pupillary defect. Slit lamp examination was normal in both eyes. For eyelid measurements, the right had normal values, but the left had moderate ptosis, still with good levator function, and exophthalmometry was normal. This is a photo of the patient's pupils in ambient light. We can clearly see the anisocoria and myotic left pupil. There are no vascular dilatations on the affected side of the face. So in evaluating a person with anisocoria, what is the first step that we have to do? Do we do a pharmacologic test with phenylephrine drops? Do we do imaging, or do we check pupil sizes in bright and dim light? The answer is letter C. If the pupil sizes remain the same in bright and dim light, then the anisocoria is physiologic, but if they vary, then there is an underlying pathology. This is the photograph of the patient, and the picture above was taken under bright light where his right and left pupils measured at 3 and 2 millimeters. The picture taken below was in dim light, and anisocoria was greater with right and left pupil sizes of 5 and 3 millimeters. There was no light near dissociation elicited. The rest of the eye exam was normal in both eyes, and these are our salient features. So, in a patient presented with acquired unilateral ptosis, we can be guided by this algorithm. We must always remember to check the pupils first, as this may be easily overlooked. We can then check for the presence of anisocoria. If present, 2 differentials could be either a Horner syndrome or a cranial nerve 3 palsy. In anisocoria, which pupil is the culprit in Horner syndrome, and which is the culprit in cranial nerve 3 palsy? So in Horner syndrome, the answer is the smaller pupil which does not dilate properly in dim light, suggestive of a problem in the sympathetic pathway. While for cranial nerve 3 palsy, the answer is the larger pupil which does not constrict due to inadequate parasympathetic input. Therefore, we were highly considering Horner syndrome in the patient. As we may recall, Horner syndrome is attributed to oculosympathetic paresis caused by the interruption of sympathetic pathways that supply the head and neck. It is usually comprised of a triad of ptosis, meiosis, and anhydrosis. This is the diagram of the oculosympathetic pathway, and here we can also see the location of the central preganglionic and postganglionic neurons. In diagnosing Horner syndrome, pharmacologic testing needs to be done, and these are the 4 topical drugs as indicated on the right lower box used to do so. Among these, K.A.K remains the gold standard for diagnosis as it would readily dilate a normal pupil but not the abnormal one. However, this is not readily available in most countries. Aprequanidine dilates the abnormal pupil but it does not localize the lesion. To do so, we can use hydroxyamphetamine, which would dilate the abnormal pupil with a central or preganglionic lesion, or 1% phenylephrine, which would dilate the abnormal pupil with a postganglionic lesion. In our country, only phenylephrine is readily available for use in the clinic. So we instilled 1% phenylephrine eye drops to both eyes, and 10 minutes later, there was noted improvement of the ptosis of the left upper lid. 20 minutes later, the left pupil was dilated compared to the right eye. The lesion was thus localized as a postganglionic involvement. So it does look like Horner syndrome. But wait, our patient only presented with ptosis and meiosis but not anhidrosis. Is this possible? The answer is a resounding definitely. After synapsing at the superior cervical ganglion, postganglionic pseudomotor fibers follow the ECA to the face, while the sympathetic fibers to the eye travel via the carotid plexus of the ICA, carrying only a few sweat fibers for the skin. Thus, anhidrosis occurs only in patients with a central or preganglionic lesion, but never with a postganglionic lesion. This definitely coincides with our finding with the use of 1% phenylephrine, which dilated the abnormal pupil. Based on other case reports, there are 3 likely mechanisms which could have occurred during surgery that led to Horner syndrome, and these are the following. A case series showed that the risk of Horner syndrome increases in more extensive surgery for malignant thyroid disease with level 2 lymph node dissection, just like what happened in our patient. With regard to prognosis, case reports have shown that 70% of patients had permanent damage or incomplete recovery, while complete recovery was noted 5 days to 15 months after surgery. 5 months after the initial consult, we saw the patient once more, and there was still no change in his ptosis and meiosis as seen in the topmost picture taken in ambient light. The second photo was taken in bright light, while the one below is in dim light. To date, there are only 30 cases reported of Horner syndrome occurring after thyroidectomy, and prognosis varies, ranging from complete recovery to permanent nerve damage. Therefore, surgeons should be aware of such outcomes and proceed with caution in manipulation of nerves and associated structures. The icing on the cake remains to be a good and thorough history and physical examination so that we do not miss out on anything. Finally, as ophthalmologists, we must suspect Horner syndrome in patients with anisocoria and ptosis with a history of neck surgery. Our complete diagnosis is moderate neurogenic ptosis with good levator function, left, secondary to post-thyroidectomy, postganglionic Horner syndrome. These are my references. Thank you very much.